Welcome back to the Now Morning Show. We are celebrating, and observing, I should say rather, breast cancer awareness right here on the show. This, as Rokas Aniankoda said, fantastic Friday. We're talking about the theme of keeping her in the picture, and joining us in studio is Dr. Lyronne Olivier to share a bit more. Good morning, Doctor.
Good morning, good morning.
How are you today? It's a pleasure to have you with us on the show. I think I'll say welcome back because you are a part of the show as well, we like to say. Tell us a little bit about breast cancer awareness in particular. Let's start with something we would have touched on this morning in trending, some of the risk factors that we need to look out for.
So generally, as physicians, when we talk about risk factors, we talk about factors that you can change and factors you can't change. We label that as modifiable versus non-modifiable. Rokas actually described a fair amount, so I was quite impressed. He made my job a lot easier. So the ones that you cannot modify is just the mere fact of being a woman.
Right.
Rokas mentioned that 1 in 8 women actually have risk of getting breast cancer in their lifetime. So that works out to about 12% lifetime risk of breast cancer. So the mere fact of being a woman, you can get breast cancer. The other fact is as well age. As you get older, your risk for increased breast cancer. For example, if you in your 30s, your risk for breast cancer is 1 in 227, which works out about 0.003. And if you jump straight up, let's say up to the age of probably about 70, that's 1 in 24. So that works up to probably be, a higher percentage, significantly higher than a person that is in 30s.
So it's fair to say as you get older, obviously your risk increases.
Older, the risk for breast cancer actually increases.
And what about in Trinidad and Tobago? I mean, I know we're going to delve a bit further into statistics as the conversation continues, but in Trinidad and Tobago in particular, how do these numbers relate to our society?
I mean, we can talk about what I see on a daily basis.
Yes.
I really think that I work in St. James as well. That's in the public system. There's a significant number of patients around the age of 40. And I would say, at least I see a fair amount too at the age below 40. And I actually have 1 or 2 patients at the age of 20-something, which is crazy.
My goodness.
But definitely at the age of 40, there is a significant increase. And this is seen worldwide as well, because initially this age for screening from WHO is at age 50. NCCN, which is a body that we use to make guidelines for treatment, was at age 40. America was at age 45 and 50, and now everybody's coming down to the age of 40, which again states that they're seeing us a decrease and an increase in terms of a decrease in the age, but an increase in numbers at that particular age. So it's staggering as well. And the thing is as well, when you get cancer before the age of 50, you still have a high estrogen hormones in your body, as Rokas was mentioning about estrogen exposure.
Right.
And the cancers tend to be a lot more aggressive when you're younger versus a more mature woman in her 70s or 60s. We tend to get a more aggressive type of cancer. So it really, even presenting at an early age, unfortunately, it even tends to be a little more aggressive than a more mature woman.
Wow.
So that is quite interesting as well.
It is interesting, and it's not something you would necessarily think about, because you always think, the younger you are, the stronger you are, the easier it's going to be to fight it off, and your body's going to just be healthier, have a better immune system. But you just mentioned the screening ages being adjusted, but you also mentioned that in Trinidad and Tobago, you have seen those as young as in their 20s. Yeah. So is it recommended that perhaps we take the initiative ourselves and start to screen from younger? So
the screening recommendations really start at age 40 because of a number of factors. Because screening is the ability to pick up something before it's even visible. So you have a issue going on before it becomes visible. And the certain investigations that we have is deemed better at that age group.
Right.
So if you look to go and do those same investigations in a 20-something-year-old or a 30-something-year-old, it may not be that efficient. So there's a bit about risk stratification.
Okay.
So you have someone walking on the street, they have a particular risk. That's the average street risk. And then you have someone who has a family history of breast cancer. They're going to have a higher risk of breast cancer, so they maybe need to screen earlier, and then we may use other modalities for that screening group. Yeah. So general modality for screening is at age 40, and that's normally a mammogram. And then we do adjuncts like an ultrasound scan. If someone, for example, has a strong family risk of breast cancer, then we may start screening at age 30 with breast MRIs. But breast MRIs, again, is an MRI scan of the breast, really is for that high-risk group, not for the normal public, which is generally like mammograms. That's why you need to get risk stratification by a physician to know what risk you're falling in terms of your family history and what have you.
So this is why it's so important that we continue to do our general checkups at least, what is it, once a year, once every 6 months?
So I would say by age 30 or so, you should start, being aware of your breasts. At least start your self-examinations, and start probably getting a physician exam at that age, and then you may alter it every other year or every year. But definitely by age 35 and going up to age 40, you probably want to have your yearly exams, and by age 40, you start your screening.
Okay, so that's something definitely to note. Now, What would you recommend that women can do? I mean, they say, what is it? An ounce of prevention is better than a pound of cure. But are there things that we can do as women to, in some ways, I guess, just stave off the possibility of this happening?
So that brings us back to the factors again. So the factors again, as we just re-emphasizing, the age being a woman, age of which you start seeing your menstrual cycle, age when your menstrual cycle stops. Those are factors that you cannot modify. And then the modifiable factors, is just risk association. We're really not too sure.
Right.
We know that 10% of breast cancers is something that in your genes that passed down from your family. And that big 90% is sporadic, meaning that we don't know. So factors that you'll actually think is the opposite way around, but only breast cancers, 10% of breast cancers are actually caused by a genetic mutation. And I actually did a study in St. James where I compared our high-risk group of patients that came in, and 13% of our patients who had breast cancer had a genetic mutation. So it's equivalent in our population as well.
Wow.
So generally, the risk for breast cancer, 90% is sporadic. And that things like, for example, where you can modify things like your diet.
Right.
We know that there's like a 35 to 40% reduction if you eat a healthy diet. What is defined as a healthy diet? That's for another discussion. It may vary from person to person. In terms of exercising, can reduce the risk of breast cancer, again, by 40%. Things, for example, avoiding alcohol, which will be a very trending topic. I'm sure I'm probably going to be discussed. But definitely, we know that 10 grams of alcohol increase the risk for breast cancer by 7%. Yeah?
Wow.
And one beer has about 14 grams of alcohol. So if we start talking about spirit and we start talking about wines,
Right.
which one we have a higher quantity of alcohol, depends on what you drink, your risk of breast cancer increase. And it's a direct link. It's directly proportional risk of breast cancer if you drink alcohol. So I generally say cessation of alcohol will significantly reduce your quantity of alcohol.
My goodness gracious me, I don't think anybody is going to be watching a beer or any sorts of alcohol the same way again after this conversation
So
this morning.
It's known for sure. Yeah?
It's known for sure.
And then Rufus had mentioned, Ruckus had mentioned about talking about oral contraceptive pill. That's a transient risk.
Okay.
Yeah? Where it's a risk that if you discontinue the oral contraceptive pill, it actually goes away after 10 years. And it's mild, it's significant. It's probably like 0.1%, 0.1 relative risk multiplied by your risk factor.
Okay.
And then once we talk about that too as well, another big factor is when women stop seeing their menstrual cycle, they go on hormone replacement therapy.
Yes.
Hormone replacement therapy has a significant risk. It's about 7.6% increased risk for breast cancer as well. Yeah, and again, just like the oral contraceptive pill, once it's discontinued, then the risk is reduced. That's why it's important to go to a physician when you start these medications and have that discussion. And I think sometimes it's important for the patient themselves to be knowledgeable about it so they can express that concern to the physician. Because if you have a strong family history of breast cancer, then HRT is not for you.
For you.
Yeah.
So that's the other thing as well, especially as you mentioned HRT, because you do see many women go on hormone replacement therapy when that time comes. So then what alternatives are there? Or are there alternatives at all? That can be used?
It depends on the symptoms that they have in the postmenopausal phase. There are topical creams you can utilize to improve some of the symptoms as well. And again, probably there's diet modifications and trying to improve the side effects by other means.
Right. Heavy focus on diet this morning as well, and of course what we ingest. I mean, we see it all the time. We'll see, packs of cigarettes with all these different images on them and warning labels and all these things we put into our bodies for some sorts of, let's say, immediate gratification definitely can have long-term effects on us. Now, I just want to go back to, before we came on air this morning, one of the things you mentioned is also that men can be susceptible to breast cancer. Now, we understand, of course, the theme is keeping her in the picture, but we can't leave the men out. So can you share a little bit about that?
So 1% of all breast cancers, be it male or female, is actually associated is because of male breast cancer. So men can get breast cancer. I think I wrote an article about it about 6 months ago because it is important to know, because most people don't think men can get breast cancer because they don't have breasts.
Right.
Men, we actually do have breasts. We have breast tissue behind our nipple. It may vary, depending on the person themselves, but we do have that breast tissue. And once you have that breast tissue, it could have a potential of becoming breast cancer. It's very rare. As I said, it's about 1% of all breast cancers. And generally, it presents similar to female breast cancer. It may present with a lump, it may present with some swelling, it may present with redness, it may present with some changes in the nipple. But generally, it tends to have the thought that it's worse than female breast cancer, but it's pretty much the same cancer, but men take a longer time to present. Also, because we have a smaller amount of breast tissue, the response of the lesion itself goes directly into the muscle itself a lot faster. So it presents at a later stage. Stage is where how we compare people internationally in terms of their cancer. So the stage tends to be a little later than when a female represents. So they tend to have a more aggressive course of the disease because of their stage of presentation. But the same cancer and the same management.
Now, when you say aggression, are you speaking of how rapidly it can go and build through the body?
Yeah, so some of the things I really like to focus on in managing breast cancer now is really personalizing care.
Okay.
I think every individual should be treated in a particular manner, not just group everyone into a particular, you have breast cancer and this is your management. I think it should be firstly what the patient desires in terms of what the options are, but also the features of their cancer. So now the technology and the information and the pathology of the cancer is being understood a little more. So we know we can classify the breast cancers in terms of it's what we call, I like to tell patients, the antennas or the receptors on the cancer, so we can predict its behavior. Okay. So each cancer and each breast cell has certain elements on it that helps us to predict its behavior and also predict the plan of action in terms of treatment. So you have things like estrogen, progesterone, and HER2. Those are certain antennas on the growth of cancer which responds to hormones, and that stimulates and makes the cancer behave in a particular manner. So if we know your cancer, we can categorize you into some major groups. So we talk about hormone-positive cancer, we talk about triple-negative breast cancer, we talk about HER2-enriched cancers. And based on those different patterns, we know different treatments are going to respond. So the hormone-positive cancer responds to blocking the hormones.
Okay.
The triple-negative cancer really don't respond to blocking hormones, but they respond to chemotherapy.
Right.
The HER2-enriched cancers really respond to a special awesome drug that we have that is an antibody that binds to the receptor and kills the cancer. So we know that the hormone-rich cancers are the more elderly patients tend to get slow growing versus the triple-negative and HER2 cancers. Those are the cancers tend to be a little more aggressive, and unfortunately, those are the ones that the younger patients get. But technology is improving so much. There's research I did in my fellowship in 2020 has changed tremendously and become mainstream now. There's special antibodies, special drugs, things we are changing up. For the triple-negative and HER2, we actually get something what we call a complete pathological response, where the cancer can totally disappear.
Oh, wonderful.
Which is awesome because we know that these cancers, the triple-negative and HER2-positive cancers, like to come back in 3 years. So we know once you get that complete pathological response, your disease-free survival, which is the chance of the cancer coming back, is a lot less. So it's really awesome where we are in terms of breast cancer management. We are improving daily, and all of these things, most of these things are available in Trinidad.
I was just about to ask that, whether or not it is available in Trinidad and Tobago, because many times the one term that we always hear when you either know somebody or associate it is chemotherapy.
Yeah.
So it's wonderful to hear that these are available. We are almost out of time. So before we wrap this conversation, do you have any words for those who may be affected by breast cancer?
I always tell my patients, I give a talk sometime to the group of ladies that are there waiting for the clinic, especially in breast cancer month, but I always think that, there must be some positivity to this negativity. And I think what you guys are doing here and what, coming back, and probably it's the same thing. I was thinking about what different could I say when I come here. There's not much I can say differently, but awareness. It's all a matter of myself telling you guys I have a patient with age 25, not to bring anxiety, but to bring awareness. If you find an abnormality in your breast, seek a consultation. And the whole key, when you come to me, I want to be able to cure you. I don't want to be palliative or try to reduce the effects of the chemotherapy and the drugs. We want to be able to remove that lump and get rid of that disease if it's confined to the breast. So it's all about awareness, and I'm really awesome that I was able to bring that forward today.
It's wonderful to have you. Thank you for being with us, and we look forward to having you with us on the show again soon.
Definitely. Thank you so much.
Trinidad and Tobago, Dr. Lyronne Olivier right here on the Now Morning Show, as we have a special edition this Friday for breast cancer awareness. Stay tuned. There's more coming up.